Hello, everyone. My name is Mihir Chauhan, and I'm going to be going over a review of my article, Modified Minimal Contact COVID-19 Workflow Allows for Safe Remote Parenteral Nutrition Prescribing in Non-Critically Ill Patients. This was a study done by a Singaporean group at their major hospital. Before we get into the study, just a quick background on COVID pathology that we're all really familiar with right now, or by this time. We know that SARS-CoV-2 leads primarily to a respiratory disease that can involve the upper and lower respiratory tract that requires not only respiratory support, but also in extreme cases, intensive care. Those persons that are afflicted with comorbidities such as diabetes, cardiovascular disease like congestive heart failure or hypertension, or who are the elderly, usually above the age of 65, are susceptible to a higher risk of infection, of incurring infection and of getting complications. Notably, patients who are of old age or have pre-existing comorbidities are associated with a higher prevalence of undernutrition. And undernutrition is usually referred to as malnutrition in clinical settings. So for the purposes of this paper and this presentation, we'll be using the word malnutrition. And it's important to know that malnutrition is an independent cause of morbidity and mortality in many disease conditions, obviously not just, after getting COVID. A little bit more background on this study. There is a high prevalence of malnutrition in COVID-19 patients that suggests a correlation between a high risk of infection in individuals that suffer from malnourishment. But this is kind of like that diabetes question that we talked about earlier in the semester. Do patients that have diabetes get COVID? If getting COVID, is your diabetes worsened? There is a correlation, but precious little information in terms of causation. So this is a bit like that, but we do know there's some association between malnutrition and being afflicted with the COVID virus. We know malnutrition has a negative impact on COVID-19 prognosis. So that is to say, being malnourished worsens COVID's pathological severity in any given person. And other complicating factors include things like COVID-induced inflammation, organ failure, immobilization, where you're just kind of stuck to a bed, and skeletal muscle mass loss, and therefore resulting in a negative impact on a person's nutritional status. So COVID has a negative impact on body weight, no matter where you are, whether you're hospitalized and non-hospitalized. And so we should appreciate that this is kind of like a vicious cycle. If you're malnourished, you most likely are going to be incurring COVID. If you do get infected with the disease, the chance you have or the risk of getting more complications from COVID increase, and that'll make you even more malnourished the longer you are inflicted with COVID. So in terms of this study, the overall design was a prospective cohort investigation. And this group of investigators were from, as I said, the Singapore General Hospital. And basically they sought to compare the efficacy of giving parenteral nutrition, which is essentially giving nutrition, proteins, fluids, micronutrients, etc., into a patient that needs them through any means that's not having to swallow it from your mouth. So almost always this refers to setting up an IV line and giving IV fluids and IV nutrition. That's what parenteral nutrition, or PN, refers to. And so the authors of the study are comparing the efficacy of giving PN using a modified minimal contact method after there was worldwide recognition of the COVID outbreak. So specifically, that refers to a period from February 5th, 2020 to April 15th, 2020. So between those months, from February 5th to April 15th, they gave PN, parenteral nutrition, using a kind of modified or novel minimal contact method. And they compared that with PN administration in a daily in-person, like physically you had to be next to the patient's bedside, physical review during a set period before formal recognition of the outbreak. And so that period included December 5th to February 4th. Now, there was COVID during that time. That's about the time that it kind of leaked out from Wuhan, maybe even earlier than that. But for the purposes of the study, they're calling that the before COVID period. And so what's important to note is that in this prospective cohort study, the exposure amounts to a protective factor. And that protective factor is parenteral nutrition given by healthcare professionals using their special minimal contact method. And the exposed group in this case is the group that received that type of nutrition during that quote unquote COVID period. So from February to April. And the unexposed group is the group that received traditional forms of support in that before COVID period. Usually we think of exposure as being some kind of something that has deleterious impact. That's usually what prospective cohort studies are, I believe. So if you were to study, let's say, the effect of nicotine on lung cancer, you would have an exposed group that was exposed to nicotine, maybe they were cigarette smokers, and you would follow them forward in time to see if they developed any kind of cancer, throat cancer or lung cancer. And the unexposed group would be people that stayed away from that stuff. And you would follow them to see what kind of outcome they had. In this case, the exposure is hopefully the healthcare professionals doing something good for you and seeing what effect that has. So a couple of definitions that pop up that we should know about that pop up in this study. Cluster care refers to all of the attempts to bundle care in as tight of a package as possible in order to limit the exposure of those healthcare professionals to the patient. And that basically involves three things. Firstly, remote interventions. So you try not to be physically in the same room as the patient. Number two, when you do have to be with the patient, safety is of utmost importance. So you always have to have PPE on. And the extensive use of information technology for communication between the different team members that are part of the patient's care. And another term that kind of pops up often is IF, or intestinal failure. This is a specific definition that refers to a reduction in gut function below some kind of minimal level, a minimal threshold. And that threshold is necessary for the absorption of macronutrients, water, and electrolytes. And when you go below that level, that's when you need that IV supplementation, or PN, in order to maintain good health. So in terms of study design, the at-risk population, there were basically two different cohorts. As you have in all prospective studies, you have the exposed and unexposed cohort. So the first one involves 49 patients, and they were part of the before COVID group, so from December to February. And these were the people that were not exposed to PN via that modified, improved workflow. And then an additional and separate 56 patients that were given PN via that modified workflow, the exposed group, in the so-called COVID phase of the study. And the baseline characteristics between the two groups, if you are to have a kind of robust study or investigation, have to be fairly similar. And in fact, they were, and I was kind of happy or impressed to see that. And so the different groups of patients were matched in terms of them presenting with ileus or some kind of GI obstruction. Ileus refers to not being able to move your bowels. It basically just means that your GI tract from anywhere between your esophagus to the rectum is slowed down. It just doesn't move peristaltically in order for you to absorb nutrients. And an obstruction can be any kind of obstruction in that entire tract. The presence of enterocutaneous fistulas in the two groups were also the same. The amount of GI hemorrhage that patients underwent, people that had underlying malignancy or cancer, the presence of mucositis, and just the overall BMI, the body mass index. So between the two groups, all of these different categories were matched, and they were very similar. There were some other small ones too, like graft versus host disease, which we won't really get into too much, and a few other, smaller categories. The patients that did present with ileus or obstruction were, we should note, right at that cutoff value of 0.05. You would want, for this to be significant, for the difference to be less than 5%, right? A p-value of less than 5%, and that the ileus or GI obstruction crowd or aspect of both groups was right at that cutoff of 5%. So a little bit more about the study design. The modified workflow involved having MD doctors, gastroenterology fellows that were assigned to a certain geographical area of Singapore, and they would attend to new consults or new patients under the supervision of an NST or nutrition support team. And the GI fellow would review the admission history of that patient. So basically their, medical history and history of present illness, and they would perform a physical exam, and that part would be done in person while the doctor was in full PPE. And if they determined that PN was warranted for that patient, it would be prescribed via a computerized provider order by the support team, by the NST. So the daily physical review of patients like this was replaced by a team of NST pharmacists, dietitians, and physicians that would meet in a non-clinical area while practicing social distancing. So really they would see the patient just the one time when they admitted them. I think there were 2 exceptions to this rule, but basically just you would see them the one time when you actually brought them into the hospital. The outcomes of this study were very straightforward. There were primary and secondary outcomes. The primary outcomes does have a very important caveat, very important, and we'll get to that a little bit later in a few slides. And the primary outcome is measuring the proportion of patients that reach their energy target within 5 days of administering parenteral nutrition, meaning that the modified workflow of PN worked. It was effective if you hit that primary outcome. And the secondary outcome was measuring rates of hypo or hyperglycemia, making sure your patients didn't have too much glucose or too less glucose in your blood, and catheter related bloodstream infections, or CRBSI, which is basically something you have to look out for if you have someone with an IV line for an extended period of time, that they're not getting an infection from that IV. So here are the results of the study. The left-handed column is the before COVID group, the 46 patients, and the right-handed column is the during COVID. And you'll see that that the difference between the two groups has essentially an NS, or a p-value that is not significant, meaning that the difference in both groups was not very big. It was virtually similar. And that's exactly what you want. Having no difference between the groups essentially determines success. At the very top left, you'll see something called an SGA score that stands for Subjective Global Assessment. And that's essentially a measurement of malnourishment. It has subcategories like A, B, and C, and then you can combine B and C. We don't have to go into all of those details, but in the before COVID group, when parenteral nutrition was being given in a traditional format, you had some level of success rate. And during COVID, when you were hardly even seeing the patient in person, the rate of success that you had was basically the same as for in the before COVID group. So that shows you that your modified workflow worked. The second big category of the results was in nutrition delivery. The bottom four, where it shows lipid, protein, dextrose, and median energy, show no difference between the two groups, meaning the amount administered of proteins and lipids was basically the same for the two groups. But what's important is that achieved target energy. And this is the caveat that I was talking about, because right here for the primary outcomes, it says the investigators measured the proportion of patients that had reached their energy target within 5 days. And they declared success in that respect, that they did meet, I'm kind of giving it away, that they did meet that primary outcome. But when you look at the actual results, you'll see that red box that I have on the side, and it says 0.095. That should be below 0.05. So there was a significant difference between the before COVID group and the during COVID group. So that's important. Just one more little statement on the results. This is where they looked at complications of parenteral nutrition in both groups. And that CRBSI is essentially bloodstream infection like bacteremia. And then we talked about the glucose levels, fluid overload, and actual mortality was also measured. And there was no difference between the two groups. So they're essentially saying, the authors are basically saying that PN via the modified workflow is not going to cause any harm. It's exactly the same as if you were to do it in person. So let's talk about some biases and there were a few in this study. Because this is a prospective cohort study, we should look at immortal time bias. And immortal time bias is something I had never heard of before, actually. I just learned this myself. It's a type of bias in which the period of time from which the observation of your subjects begins to the time of your actual intervention, or in this case, your protective exposure begins, is actually independent of the intervention. It has nothing to do with the intervention. You haven't done anything to the patient yet. So all you've done is kind of admit them and you're observing them, but there has been no intervention as of yet. So subjects that survive until the time of that protective exposure, so the beginning of PN in this case, would kind of falsely add to the credence of that intervention. You can falsely claim credit and say, our intervention worked because our patient survived for so and so time. Well, they survived on their own before you had intervened. So you can't kind of take credit for that. So I believe this group in Singapore kind of adjusted for this bias by staggering the groups. So what they did was have that early before COVID group where everyone was recruited pretty much at the same time. And I'm guessing, I don't know, but parenteral nutrition was started at about the same time. And then they had the second COVID group where patients were recruited again at about the same time. And when they were, parenteral nutrition was given in a very reasonably, within a reasonable amount of time, a short amount of time. So if I had to guess, there's no way of knowing, but if I had to guess, I would say immortal time bias in this case is very modest. Another thing we have to look for, which is a good thing, that speaks well to the study. Another thing we have to look for in prospective studies is non-responder bias. And it's basically unknown how, to me at least, how the investigators adjusted for this bias. It's possible that we can't generalize the results of the study because only a certain sample from Singapore's population decided to be a part of both cohorts. It's also possible that that the non-responder bias exists only in the before COVID group as opposed to the during COVID group. It's impossible to tell. So the way this study was structured leaves kind of a question mark for this kind of bias. There's also something called a misclassification bias, which, if I've understood that right from reading the professor's article, I don't think that exists in this study. So because of the staggered nature of the way they did this study and the fact that the participants didn't have a choice in the type of exposure they would receive, the differential and non-differential bias, I think, cannot or does not exist in this study. I hope I'm not wrong about this, but I think they just kind of dodged this bullet completely. Losses to follow-up are an interesting point here. The authors of the study did not discuss respondents. There was a lot that was not discussed in the study. Actually, it was a very modest paper, only like 4 or 5 pages long. And I was wondering if there was any loss to follow-up, but they just didn't mention that at all. The discussion section of the paper was about a paragraph or two long, not much to it. And they did not discuss the respondents that were lost to attrition, if there were any, during the course of the study. So this is either factually true or it was a form of bias that they just chose not to report. And so again, not knowing this creates a certain amount of doubt in the reader's mind. There were some strengths in this study. First of all, the notion that a contactless parenteral nutrition intervention in a cluster care model can be given effectively has been established by 2 groups, the ASPEN and the ESPEN. That's the American Society for Parenteral Nutrition, Parenteral and Enteral Nutrition. And then its European counterpart, the European Society for all that. And that is the gold standard of care. I think I'm beginning to run out of time, so I'll have to go quickly here. Matching and restriction were employed very effectively to manage confounding. The 2 groups did differ in their health status prior to being involved in the study. The patients who received the modified workflow in the COVID group were more malnourished to begin with. And that group also had more GI obstruction and ileus than the unexposed group. Remember, they were right at that 5% level. And this, I believe, creates a selection bias. It most likely reflects prioritization of emergent conditions and more serious cases, and patients basically self-selecting themselves to receive treatment, calling in as referrals to have a doctor see them, basically. But if you look at the results of the study, the results show that the modified workflow was very effective in its implementation. So that means despite more stringent requirements, it was actually successful in its implementation. So even though the COVID group were worse off, right, they were more malnourished and had more GI issues than their counterparts from back in December, the modified parenteral workflow worked for them just as well as it did in the other cohort, in the non-exposed cohort. So there were some questions and concerns here. Remember, the primary outcome we said was restricted to the measurement of getting target energy within 5 days and not by the end of the period. If we extend that time to the full stay of the patient, just because you're looking at 5 days doesn't mean that the patient stayed in the hospital for 5 days. It could have been for 30 days, it could have been for 6 days. So if we extend that time to the full stay of the patient, the effectiveness of the modified workflow does not show any significance. And that's what that little red box I had was right there, the 0.95. That should be under 0.05. But the reason why in the discussion section, the authors said that the primary outcome was achieved was because they didn't look at the achieved target energy for the entire course of the study. They just said, we're going to cut it off at 5 days. And within 5 days, we met our goals. So it shows that parenteral nutrition with a modified workflow worked. Well, not really. You just kind of cut off the dates to make it be significant. So we don't know how the investigators came up with their cutoff points for each group. It seems to have been arbitrary. And on greater reflection, it seems that an established a priori hypothesis might not have been tested in the study. On the face of it, and this is the really, really, really big important point that we'll end on the face of the study, it seems like COVID-induced phenomenon like malnutrition that we talked about at the beginning of this presentation was being managed effectively by the gold standard of care. But kind of tucked away in the paper was one sentence, like a single line reference by the investigators, that none of the patients in either group, the exposed and unexposed, actually had COVID. So no one had any COVID. This was just people with GI problems. So we conclude that during the peak period of COVID, a contactless modified workflow was effective in some respects to managing the care of sicker than normal people. But because no one had COVID, we can't really generalize these findings to a COVID afflicted population, which is kind of the whole point of this. And so we'll stop there. These are my references. Thank you so much for listening. And I really enjoyed the course. So thank you to everyone.